Hello 46, my name is Sean Ennis. I'll be discussing spinal cord disabilities. So spinal cord injury is an injury to the spinal cord that impairs the sensory or motor function because of an inability to transmit action potentials from afferent or efferent nerve cells. And we classify this the way the injury occurred, either traumatically or non-traumatically. Traumatically would be a mechanical force that would, from an acute event, that would damage the spinal cord and impair function. Non-traumatically, it could be from disease, toxins, ischemic ways that cut off blood flow to the spinal cord. And then we have two different types of injuries within this injury. We have primary, which is cell death immediately from that acute injury. Secondary would be complications because of that. So some ischemic ways, something is pinching a blood vessel supplying the spinal cord, will hinder its function. Inflammation and swelling from possible bone fragments from a vertebral fracture. Cell suicide, neurotransmitter imbalances. They hinder the ability of the nerve cell to transmit action potentials. These can take minutes to weeks after the acute injury to actually take place. We further classify this as complete or incomplete. Complete injury would be something, the site of the injury and everything below would be impaired. Motor and sensory. There's a few tests to see if they cut off both. Physical touch test to see if the person feels it. Voluntary movement, asking them to move the limb. Reflex tests will test to see if there was something damaged the reflex pathway in the spinal cord. Then there's quadriplegia or tetraplegia, which is affecting of both the arms and legs, which happens higher up on the spinal column. Paraplegia, which is just the legs and the lower body, which happens lower on the spinal column. Incomplete, there's some preservation of sensory or motor function in the injured areas below the site of the acute injury, and they can be temporary. People can rebound from these. There's central cord syndrome, where there's a loss of sensory in the arms, but you can regain some in the legs. Anterior, loss of most sensory functions, but you can retain some movement or gain some movement back. Then there's posterior, the opposite of that. People struggle with movement and coordination. And then the Brown-Séquard syndrome, which is just one side of the spinal column is affected, and that would just in turn affect one side of your body. And these are two different models of how to grade a spinal cord injury. Muscle function grading. 0 would be total paralysis, 5 would be full movement, full function. And then the other side on the Asia impairment scale, A would be complete paralysis. And then there are some different subcategories with that. E would be normal. You can have one or the other, motor or sensory, and that's graded based on each of the nerves on the model on the right. And some stats, 17,000 new cases happen each year. 80% are male. And a cool stat, if you wear your seatbelt, it reduces the chances of getting a spinal cord injury by 60%. And in this little pie chart, you can see that incomplete tetraplegia is pretty much, or quadriplegia is pretty much the most prevalent, where there's some function in the arms and legs, but they're both affected, and they're pretty expensive. This injury ends up costing a lot because a lot of people need full-time, year-round care if they don't bounce back. So the most common cause is trauma, specifically vehicle crashes, and then falls. Violence and gun violence. Gunshot wounds to the spine are pretty common. Non-traumatically, infections, TB and HIV, cancer and degenerative diseases like osteoporosis can cut off blood flow or pinch the spinal cord, which can kill nerve cells. And nutritional deficiencies. You see this a lot in pregnancies, neural tube defects like spina bifida. There's an exposed spinal nerve in the infant, which can easily be damaged. diagnosis at the scene of the incident, it's critical that we immobilize the person. You can't move them unless there's danger around them, and wait for emergency services. Their symptoms can be confused with spinal shock, which happens after most spinal cord injuries, which is associated with a weakness or loss of function below their where the injury took place. But regardless, any head, facial, pelvic fractures, falls, or penetrating injuries around the spine should be treated as spinal cord damage, just in case just so there's no further complications. If you move them and they actually did damage their spine, it's kind of hard to tell. You're just going to make it worse. And the two tests that actually where you can see if there's damage to the spinal cord is an MRI. CT scan shows you cross-sectional view to show you where and how bad the injury actually is. Myelogram, they inject dye in your spinal cord, and X-ray to see like broken fragments of the vertebral column that could possibly create more secondary injuries. Management, there is currently no way to reverse damage to the spinal cord. Early treatment is critical. Stabilization, mobilization, just making sure the person can breathe on their own, because anything above C4 affects breathing. So you just want to make sure that that person can breathe by themselves and prevent further complications. Continuous treatment really depends on how bad the injury is. I mean, they both do, but this one, a quadriplegic is definitely going to get different rehab than a paraplegic. So, but the main focus is to strengthen their muscles and improve coordination to promote their quality of life. And prognosis is dependent on the initial injury and the complications that arise from the initial injury, but they're different for everybody. So my case study was actually pretty cool. It was during some observation hours at a clinic in Delaware. This man came in with autoimmune disease, and it worsened and paralyzed him from his T12 down. And he was considered, high coronary risk and high risk for falling. He needed at least 2 people around him if he was moving. When he did, like the second week, the first week he was still bedridden from an induced coma to try and slow the infection. And I think he was in the coma for like 5 months. So he had a bed sore on his back. So that was another thing we just had to look out for during his rehab. So his goals were to improve quality of life and independence, improve upper body and core strength, and then he wanted to attend his sister's wedding that was 2 months away. Discussed his autoimmune disease, and he was extremely deconditioned from the induced coma and was fatigued constantly. So his initial evaluation, there's a standing frame right here on this slide, and we put him up in it. The first time he was able to get to the clinic with assistance. He needed assistance when he first came in to get up out of bed and get into a chair, and vice versa. So we stood him up in the standing frame, and he lasted about 34 seconds before he passed out because his blood pressure got way too low. And this was the first time he hasn't been in a lying position or a seated position in months. So that was his exercise test. So his prescription was pretty much 3 to 4 times a week. It was closer to 3 in the beginning, first few weeks, and then progressed to 5 after 2 weeks. He was doing 60 to 90% of his 1 RMs that are the comfortable weight, that he could handle for each exercise. And it was over the course of an hour, so he progressed to around 10 exercises, I want to say, but they're mostly body weight and free weight exercises like modified push-ups, trunk twists, modified sit-ups where he used his elbows. Chair to bed work was critical because that, is what he is going to be doing for the rest of his life. So we progressed to the standing bars at the end, but that wasn't, what he was up maybe in that for a few seconds at a time. But then he was also, like for endurance, we would do the bike ergometer for the first few times, and then really wanted him to get used to being in the chair. So that's what he did most of the time. Go up and down the hallway. I mean, at first it was just maybe half the hallway, take a break, half the hallway back, and that was it. Then he progressed to going up and down a few times each session. And he was in the rehab for around 5 weeks. And upon the just discharge, he met all of his goals. He was able to get in and out of the chair or the bed by himself. He actually attended his sister's wedding, which is pretty cool. And his home exercise prescription was pretty similar, because a lot of things he could have done, a lot of things he did in the clinic, he could do at home. So last I heard, he was still doing pretty well. So exercise testing for somebody with a spinal cord injury varies on how bad or how severe their injury is. Their pre-injury fitness level plays a huge role in the test. How long they were in the hospital for plays a huge role. Study was done with quadriplegic patients, and with the use of electrical stim, they were able to do arm ergometer as a appropriate fitness test. Paraplegics, mostly athletes, but you could give them a graded exercise test with a wheelchair on a treadmill. That would be a little difficult for somebody that was, had a injury maybe less than a year before their test. It would be a little bit tougher. They wouldn't be able to perform as well, but it'd be a good, you could perform it with a paraplegic person. And the ACSM resistance training recommendations, unfortunately, few disabled people actually regularly participate in resistance training. But the ACSM found resistance training improves aerobic fitness more than aerobic exercises actually do, because they're kind of limited in what they can do. But free weights, body weight stuff is what the ACSM recommends. At least 2 times a week, doing 8 to 12 reps with larger muscle groups, making sure you switch back and forth each session, with 2 to 4 sets for each exercise for beginners, and adequate rest. And here are my references. Thank you guys for listening.